Welcome to this explainer. Okay, let's just dive right in, shall we? Today, we are tackling the RCOG Green-top Guideline No. 36, which is all about the prevention of early-onset Neonatal Group B Streptococcal disease. Now, if you're an MRCOG candidate, listen up, because this is an incredibly testable, high-yield clinical pathway. You absolutely need to know this one inside and out. We're going to map out the chronological patient journey today. We'll start with epidemiology and screening protocols, move into antenatal care and risk factors, cover managing term labor guidelines, then preterm labor and rupture of membranes. Finally, we'll wrap up with antibiotic prophylaxis regimens and neonatal assessment and management.
Section 1. Epidemiology and Screening Protocols.
So, the incidence of early-onset GBS disease in the UK and Ireland currently sits at 0.57 per 1,000 births. Now, that might sound like a tiny fraction, but it actually represents a pretty significant increase since previous surveillance, back in the year 2000, where it was 0.48. Because of this creeping uptick, mastering these prevention protocols is absolutely vital, not just for your exams, but for real-world clinical practice. Okay, here is the golden rule you have to remember for the UK. Routine, universal bacteriological screening is a hard no. It is heavily discouraged. The UK National Screening Committee is super clear on this because testing absolutely everyone routinely might actually do more harm than good. Think unnecessary medicalization and potential maternal anaphylaxis risks from the antibiotics. But there's a huge exception. If GBS is found incidentally, say you took a swab for a completely different reason, we absolutely must offer intrapartum antibiotic prophylaxis, or IAP.
Moving on to Section 2. Antenatal care and risk factors. You really need to memorize these clinical risk factors because this is exactly how we translate risk into clinical action during antenatal care. We're looking out for things like a previous baby with GBS disease, maternal GBS carriage in the current pregnancy, preterm birth, prolonged rupture of membranes, suspected intrapartum infection, or a maternal pyrexia of 38 degrees Celsius or higher. And here is a massive exam tip. If a patient had a previous baby affected by early or late-onset GBS disease, you offer IAP immediately. You don't even need to check her current carrier status. The recurrence risk alone warrants direct action every single time.
Now you might be wondering, and honestly, this comes up all the time, should we treat GBS carriage antenatally before labor even begins? Watch out, because this is a classic exam distractor. You'll definitely get a clinical scenario where an anxious patient is practically begging for antibiotics for a positive GBS swab at 28 weeks.
And your answer? A definitive no. Antenatal eradication is not recommended. Treating vaginal or rectal colonization early in the pregnancy literally does nothing to reduce the likelihood of colonization at the time of delivery. It just doesn't work. So you've got to hold off on those antibiotics until labor actually starts. Now, the one exception to keep in your back pocket here is GBS bacteriuria. If she has a GBS UTI, you treat that infection at the time of diagnosis, and then you still offer IAP later during labor.
Section 3. Managing term labor guidelines. When our patient finally arrives on the labor ward at term, the whole clinical decision tree for intrapartum management anchors directly to her specific presentation. Internalizing this pathway is basically your best friend. Whether it's a planned vaginal delivery, spontaneous rupture of membranes, or maybe the onset of labor with a fever, understanding this logic dictates exactly when to offer IAP and when to hold back. It's a bit of a puzzle, but mastering it is essential. Let's actually pull out a highly specific scenario from that pathway. Here is a major rule for planned C-sections. A known GBS carrier who is having an elective C-section, who is not in labor and has intact membranes, does not need GBS-specific penicillin. Why? Well, because the transmission risk to the baby in this exact circumstance is practically zero. Of course, they're still getting routine broad-spectrum surgical prophylaxis, but no GBS-specific IAP is needed.
Section 4. Preterm labor and rupture of membranes protocols.
Okay, the complexity really spikes when we introduce prematurity, and for good reason. Mortality from early-onset GBS disease jumps from 2 to 3% at term, all the way up to a staggering 20 to 30% in preterm infants. So if a known GBS carrier has premature rupture of membranes at term, she gets immediate IAP, and we induce labor as soon as reasonably possible. But if a patient presents with preterm prelabor rupture of membranes, we do not routinely test for GBS. Instead, we wait. We only initiate IAP once active labor is definitively confirmed or induced. The high morbidity that comes with early preterm birth means we don't just expedite delivery for GBS before 34 weeks unless there are obvious overt signs of infection.
Section 5. Antibiotic prophylaxis regimens. All right, let's dive into the pharmacology, which, let's face it, is prime territory for multiple choice questions. You have to commit these regimens to memory. Benzyl penicillin is your absolute first-line defense. The dose is a 3-gram intravenous loading dose, followed by 1.5 grams every 4 hours until delivery. Now, what if the patient has a mild penicillin allergy, meaning no anaphylaxis? We switch to a cefuroxime, a 1.5-gram loading dose, then 750 milligrams every 8 hours. And for severe allergies, like a history of anaphylaxis or respiratory distress, vancomycin is the drug of choice at 1 gram every 12 hours. Quick side note, clindamycin is no longer recommended because of really high resistance rates in the UK.
In this context, timing is literally everything. To classify as adequate intrapartum antibiotic prophylaxis, that very first dose of benzyl penicillin has to be in the patient's system for at least 4 hours before the baby's actually delivered. The evidence strongly suggests this 4-hour window is significantly more effective at reducing the risk of early-onset disease compared to just a 2-hour window.
Section 6. Neonatal Assessment and Management.
Okay, the baby is safely delivered. Huge relief, right? But the clinical journey isn't quite over. If an at-risk mother received inadequate IAP, maybe she declined it, or maybe there just wasn't time for that full 4-hour window, her clinically well baby needs a very strict sequence of vital sign checks. We evaluate them right at birth, then at 1 hour, again at 2 hours, and then every 2 hours until they hit 12 hours of age. We do this because 90% of infants who develop early-onset infection are going to show signs within that exact 12-hour window. And what exactly are we looking for during those checks? We are hunting for these urgent neonatal infection red flags: abnormal behavior, being unusually floppy, feeding difficulties, an abnormal temperature that drops below 36 or spikes above 38 degrees Celsius, rapid breathing, or any sudden change in skin color. If literally any of these red flags appear, you stop the observation immediately. You do not wait around for investigations to come back. You treat with intravenous penicillin and gentamicin within 1 hour of making the decision to treat.
So, let's end with a final, provocative thought to tie this whole thing together. Imagine this. A term patient presents with premature rupture of membranes, completely unknown GBS status, and a temperature of 38.2 degrees Celsius. What is your immediate next step? Think about how these guidelines intersect. Her pyrexia dictates that she needs broad-spectrum antibiotics covering GBS, regardless of her unknown carrier status. Keep this kind of chronological logic sharp for your exams. Applying these rules in real-time, complex scenarios is exactly what will make you a fantastic clinician. Thanks for walking through this explainer with me, and definitely keep studying smart out there.